My name is Dr. Anthony Caiafa. I'm a lecturer in veterinary dentistry at James Cook University. I'm also a consultant at North Coast Veterinary Specialists and Referral Centre on the Sunshine Coast in Queensland. The webinar for today is Local Anaesthetic Techniques for Dentistry. This webinar will discuss what are the benefits of local anaesthetics, what local anaesthetic agents are available and what's their onset and their duration of action. Where do I give them? What are the anatomical landmarks in the oral cavity for local anaesthetic nerve blocks? How do I give them? What techniques do we use to give local anaesthetic nerve blocks? And finally, do we see any complications with local anaesthetic agents in the oral cavity? Why do we use pain management in dentistry? Well, we have diseases of the oral cavity that can cause pain. Severe periodontitis, whether it be acute or chronic, can cause pain. Gingivostomatitis in cats is definitely a disease process that causes a lot of pain in cats. Local anaesthetic agents block pain responses at the local level through the nerve blocks, and therefore they're a helpful tool for us to use in pain management for oral procedures. So we would certainly use local anaesthetic agents as a local pain management tool for extractions. So it can be used as an anesthesia and analgesia for extractions. It does allow us to lower the percentage of the volatile anaesthetic agent that we're using. So it is a very useful tool, especially when we're dealing with geriatric patients. So when we manage pain in the oral cavity, we use an approach called a multimodal approach. And this is a combination of opioid premedication, then followed by the use of local anaesthetic agents to block local pain responses in the oral cavity, and this is given prior to any dental procedure, and then followed by post-operatively by the use of non-steroidal anti-inflammatory drugs or another opioid at the end of the procedure. Usually most dental procedures cause mild to moderate pain, although when we're dealing with the management of oral tumours, the surgical management of that, we will have more severe pain, and in this situation we'll use stronger opioids such as fentanyl patches. What are the benefits of using local anaesthetic agents in the oral cavity? Local anaesthetics block sensory sensation to the teeth and to the bone, so they'll decrease pain perception. They also prevent wind-up pain, which is usually associated with upper motor neurons firing after a noxious stimulus. So what happens is, if with no local anaesthetic on board, these motor neurons will continue to fire even though the noxious stimulus is over. So we can get continued pain for several days after the procedure. So local anaesthetics do prevent that from occurring. They also will decrease our dependence on the general anaesthetic agent. So this is important in geriatrics. So we get us a much quicker recovery in our geriatric patients. They are cost effective, so they don't cost that much money. And they're usually easy to perform. They're given prior to the surgical procedure. And they also will decrease our dependence on post-operative pain relief. So we'll go through two of the most commonly used local anaesthetic agents, lignycanine and bupivacaine. Now, lignycanine has a short onset of action, around 2 minutes, and can last around 60 to 90 minutes in the oral cavity. It is approved for use in dogs and cats. It's less protein bound, and what that means is that its duration of action is shorter because it is less protein bound. The maximum dose in dogs is 4 milligram per kilo and 2 milligram per kilo in cats, although some books are recommending up to 4 milligram per kilo in cats. It usually comes in a multi-dose vial, a 2% solution, which is a 20 milligram per mil solution. Bupivacaine, on the other hand, has a slower onset of action, usually up to 8 minutes. It has a longer duration of action because it's more protein bound and up to 6 hours. The dose of bupivacaine is 2 milligram per kilo total dose. It is off-label use, so it's not registered for use in dogs and cats. In the USA, sometimes they mix lignycanine and bupivacaine together in the one syringe. I would not recommend the mixing of local anaesthetic agents, and this is something that I would not do in my dental practice. Some veterinary anaesthetists recommend up to 6 milligram per kilo of lignycanine in dogs. Both of these drugs are hydrophilic and lipophilic, so the one side of it allows it to penetrate through the tissues, and the other side of it allows it to penetrate into the nerve. There are very few studies that look at the toxic dose of lignycanine in dogs. And this study on the left-hand side by Lemo, what they did is they gave lignycanine intravenously at an increasing dose rate and looked for toxic signs. So the toxic signs would have been systemic signs. The first toxic sign they saw was muscle tremors, and this was above 6 milligram per kilo in dogs. So they recommend the safe dose is up to 6 milligram per kilo in dogs. In cats, the recommendation is up to 3 milligrams per kilo in cats. What volumes of local anaesthetic agents do we recommend in dogs and cats? In small dogs and cats, we recommend up to 1/4 cc per site. Medium-sized dogs up to 0.5 cc and larger dogs 1 cc per site. Both lignycanine and bupivacaine can be diluted with 0.9% sodium chloride. In a 50-50 mix, this can increase the volume of the agent, but it will decrease the concentration of the agent and therefore the effects of the agent. But certainly diluting the agent is appropriate if you are running out of your total dose, which is at 4 milligram per kilo in dogs and 2 milligram per kilo in cats. So what are the systemic toxicities we see with both of these agents? Both agents are cardiotoxic. Bupivacaine actually is more cardiotoxic than lignycanine, so they cause cardiac depression, and also they're both hypertensive agents, so they're vasodilators as well. This is why in human dentistry we often mix it with adrenaline, which is a vasoconstrictor, mainly to keep the drug at the local level. Both are neurotoxic. We've mentioned before that tremors seem to be the early signs of toxicity. Seizures can also be a late sign of toxicity, leading to respiratory arrest. Why do local anaesthetics not work? Well, both of them are weak bases. They work best at a pH of 7.4. So if you're injecting into a very inflamed site, this will have a low pH, the drug stays in its ionized form. So in other words, it can't penetrate into the nerve. So hydrogen ions, which lower pH, can block the liberation of the non-ionized form of the drug. So as I said before, it cannot penetrate into the nerve. The other reason why local anaesthetics don't work is we haven't given the drug in the correct site, and this is probably the biggest problem we see in veterinary dentistry. This may be what early dentistry looked like. So these days we actually only talk about two main regional local anaesthetic nerve blocks: the caudal maxillary nerve block and the caudal mandibular nerve block. There are other nerve blocks that we can use in the oral cavity, but these two are the main ones that we'll use. The reason why we don't use the others, we'll go through them. The infraorbital nerve block, this is where we inject through the infraorbital foramen. The problem with that nerve block is it doesn't work for maxillary premolar 4, which is a tooth that we commonly need to work on or extract. And the other problem is that the nerve is within the infraorbital canal, and so we will damage the nerve when we give this injection. That damage won't last for very long, but I get worried now if I damage a nerve. The major palatine nerve block is usually given at the same time as the infraorbital. So if we don't give the infraorbital nerve block, we don't need to use the major palatine nerve block, because the caudal maxillary nerve block will block the major palatine and minor palatine nerves. The rostral mandibular nerve block, which is also called the mental nerve block, this is given into the middle mental foramen in the mandible. Again, this isn't often used because of damaging the nerve, because you're actually injecting into the nerve or around the nerve in that area. Just remember that with any injections that you give, we use as small a gauge needle as possible, 25 gauge or smaller, preferably 27, 29 or 30 gauge needles. We do need to aspirate, so we need to draw back before we inject. We've got to make certain we're not in a blood vessel before we inject. So here's some of the landmarks that we use for our nerve blocks. So for the caudal maxillary nerve block, we give an injection behind the last molar tooth into the pterygopalatine fossa area here. And so this injection will block the maxillary nerve that travels from the foramen rotundum. So it's traveling from around here through the pterygopalatine fossa, and then goes through the infraorbital canal and exits here. So this nerve block will actually block all the teeth in that quadrant, also the lip, the nares, and the hard palate as well. So it's quite a handy nerve block. It also will block the soft palate. So if you're doing soft palate surgery, you can use this nerve block in a bilateral approach for soft palate surgery. The other landmark that we use is the mandibular foramen. So this is on the medial side of the vertical ramus of the mandible. So this is the vertical ramus of the mandible here, and the mandibular foramen is on the medial side in line with the angular process. So this is the angular process, so it's in line with the angular process, around 1/2 to 2/3 from where the vertical ramus meets the body of the mandible. So this is the body of the mandible here. So this nerve block will block the teeth on that side of the mandible. The nerve runs through the mandibular canal through here. It exits at the caudal mental foramen, the middle mental foramen, and also the rostral mental foramen. This nerve block will block all the teeth on that side, including the canine tooth. We inadvertently do block the lingual nerve, so that will block the rostral 2/3 of the tongue, but it will also, the lingual nerve also supplies the lingual mucosa and the floor of the mouth. So we do like to block the lingual nerve to block the floor of the mouth and the lingual mucosa on that side. The nerve comes from the foramen ovale up in this area here and travels down above the condylar process and enters the mandibular foramen in this area here. So just to go through that again, here we have the maxillary nerve here. It goes through the pterygopalatine fossa. It does give off branches, the major and minor palatine branches here. It travels forward, enters the maxillary foramen here, and then goes forward through the infraorbital canal and then exits here. The mandibular nerve exits at the foramen ovale here, so it will go forward and enters the mandibular foramen and travels in the mandibular canal. It does exit at the caudal, middle and rostral mental foramina, but it also travels forward inside the bone as the incisive canal to supply the canine and incisor teeth. This is the lingual nerve here. So the lingual nerve branches slightly caudally and dorsally to the mandibular nerve. It's a branch of the trigeminal nerve, the third branch, and it will supply the lingual mucosa, but also will supply 2/3 of the tongue. And the other branch that comes off also is the buccal nerve. So this is the buccal nerve. It will supply the caudal teeth, the buccal mucosa of the caudal teeth, up to about premolar 4. So it's also a nerve that we will block when we give the mandibular nerve block. We'll talk about the caudal maxillary nerve block. So this blocks the maxillary nerve as it branches into the infraorbital and palatine nerves, the major and minor palatine nerves. It does give complete anesthesia and analgesia to the maxillary teeth, the gingiva, the mucosa, the lip, the nose, the muzzle, and hard and soft palate on that same side. So it is a handy nerve block if you have to do surgery on the nares for, say, a brachycephalic dog, or due to trauma to the lip where you have to do some suturing. It would be a nerve block that you could utilize. Normally we bend the needle at 45 degrees to the vertical, and this allows us to come from a rostral caudal direction, and we place that needle behind the second molar tooth in the maxilla, and we usually go half the height of the mandible in the first molar region. We'll talk about that soon, and that's how deep we go into the pterygopalatine fossa. In cats, it's a demarcation between the injection sites, a demarcation between the soft and hard palate, just medial to the distal root of premolar 4, and we'll show you that landmark as well. This is a deep dissection of the face. We have the maxillary nerve and its branches here. You can see the yellow it's quite a thick nerve. It sits below the eye, so the eye is here. So this branch sits below the eye. We do have the maxillary artery and vein running in this area here. So you definitely, when you're giving this injection into the pterygopalatine fossa area, you want to make certain that you draw back and make certain you're not in a blood vessel. We also use a very small gauge needle, just in case if we do pierce this artery or vein, that we don't get a hematoma forming in this site, because we do occasionally see that as a complication, hematoma forming in this site here, and it causes exophthalmos of the eye, so the eye starts to protrude. So it's something that we need to be aware of. Here we have the branch, the buccal nerve branch of the mandibular nerve here. This is the lingual nerve branch as well, and then we have the mandibular nerve. So you can see the mandibular nerve before it enters the medial side of the ramus of the mandible. It's quite a large nerve. This is quite a large nerve. The maxillary nerve is also quite a large nerve. So when we give the injection for these nerves, we're not always right next to the nerve, so we have to rely on diffusion of the anaesthetic agent to the nerve. So the anaesthetic agent has to diffuse, and this is why volume is important, because the greater the volume, the better chance of anaesthetizing that nerve, and the same with the mandibular nerve as well. So if you look at the photograph on the left side, we have the relationship between the major palatine nerve and the maxillary nerve. So the major palatine, the maxillary nerve comes through here. It goes through the maxillary foramen and then exits here at the infraorbital canal, but it does also travel forward in the bone to supply the teeth, the premolar teeth, the canine and incisor teeth. It does give off a branch that goes through here and goes through the palatine canal and exits here at the major palatine foramen here, and then that travels forward. You can see a little groove, and then it will enter the palatine fissure here. If you look at the photograph on the right hand side, here we have the maxillary nerve here. So it's coming from the foramen rotundum and entering the maxillary foramen here. So our injection is given just behind the last molar tooth. So this is the second molar tooth here. We bend the needle at 45 degrees. The length that we run the needle in is usually half the height of the mandible in the first molar region. The needle is run parallel to the tooth roots, so it runs parallel to the tooth roots. We use a small gauge needle and we draw back and then slowly inject. So you can see the anaesthetic agent will start to diffuse into this area here, which is what we want it to do, and we'll get a block of that nerve. You'll know if your nerve block is working, because if it's not working, usually when you inflict any noxious stimulus on the animal, the heart rate will go up, the respiratory rate will go up, and probably the blood pressure will go up as well. So that's telling you that your nerve block is not working. So when you work out your total dose, you have to leave a little bit up your sleeve to be able to give some more anesthetic. Normally when I give nerve blocks, if I'm working on the left side of the animal, I'll give the caudal maxillary nerve block first when I'm working in the upper quadrant. And then once I've done that work, I usually use lignycanine, and then I'll give my caudal mandibular nerve block on the same side when I'm working on the lower quadrant. And then when I roll the animal over to repeat the local anesthetics for the other side, I can go back to my total dose of 4 milligram per kilo in the dog or 2 milligram per kilo in the cat, because by that stage the anesthetic agents are starting to wear off on the side I just worked on. The other landmark that we use is the maxillary tuberosity, which is behind, that's it here, it's just behind the second molar tooth. So it's a demarcation between the hard palate of the maxilla and the soft palate, so in this area here. Next we have a video of the caudal maxillary nerve block using the intraoral approach. It will show you the needle depth into the pterygopalatine fossa area, and as I said, we measure half the height of the mandible in the first molar region to work out how deep we go with the needle into the pterygopalatine fossa. So here's the video of the caudal maxillary nerve block. We've measured half the height of the mandible. We've bent the needle. As you can see, we're passing it behind the last molar tooth to the depth of the bend. We draw back, make sure we're not in a blood vessel, and then we slowly inject, slowly inject. Some veterinary dentists will draw back again to make certain the needle hasn't moved. And we'll pull out. The landmarks for the caudal maxillary nerve block in the cat are different to the dog. So here we have the landmark. So we have this palatine bone here. This is a palatine bone here. It fuses with the maxillary bone. We have this sort of notch in the palatine bone which you can palpate in the cat. So the injection is given just to the lateral side of that notch, because the nerve will be running in this area here, So again, how deep do we go in? We go in no more than 5 millimeters. And the reason for that, cats are nocturnal animals. They have a much larger globe than dogs. We also will be careful in brachycephalic dogs as well, because they have a large globe. So we don't want to go in more than 5 millimeters into the demarcation between the hard and soft palate. We draw back, make certain we're not in a blood vessel, and then we slowly inject. So this is a video on that injection. The needle is only going to go in 5 millimeters there. We've got to be very careful. I sometimes will get someone to do this injection for me once I've held the needle in the correct position, where we just slowly inject into that area here. You can see that we're more medial. We're much more medial than we are in the dog, so we're much more medial. It's usually just medial to the distal root of premolar 4 or the first molar tooth, which will be here. So we're just more medial into that little notch in the palatine bone. So this is the reason why we don't do the rostral or infraorbital nerve block in cats or brachycephalic dogs, and I tend not to do it in any dog or cat now. And the main reason is the infraorbital canal is very short. And what I mean by that, it's only to about there in the cat. So if you place the needle in too far, you'll be into the pterygote palatine fossa area, and the globe is sitting in this area here. So we just got to be careful with this nerve block. We don't recommend using this type of nerve block in cats or brachycephalic dogs. The maxillary foramen, which will be about here, is about level with the medial canthus of the eye. So I would not recommend this nerve block, because there have been case reports of globe penetration following the maxillary nerve block, especially this nerve block. So the next major nerve block is the caudal mandibular or mandibular alveolar nerve block. Now this will block the mandibular nerve as it enters the medial surface of the ramus of the mandible at the mandibular foramen. Often the lingual nerve will be blocked inadvertently. This can be volume dependent, so in other words, the smaller the volume, the less likely you have of blocking the lingual nerve. But as I said to you before, we actually do want to block the lingual nerve because it supplies the floor of the mouth on the lingual side and also the lingual mucosa. So we do want to block that area. That's why I tend to use lignycanine, because it's much shorter acting, and I would not use bupivacaine for this nerve block because of its longer action, and that therefore the tongue, the rostral 2/3 of the tongue may be numb for up to 6 hours. Whereas with the lignycanine, the rostral 2/3 of the tongue may be numb for around an hour to 90 minutes, and by that stage usually the procedure's nearly close to being finished, and it will be wearing off. I don't try to give a bilateral mandibular nerve block at the same time. I tend to stagger it so that at least one half of the tongue is starting to get its sensation back as the animal is recovering. Now, if this nerve block is successful, it will block sensory innervation to all the mandibular teeth on that side of the mandible. And as we mentioned before, it'll block the lingual nerve and the lingual gingiva and that side of the tongue. You may not completely block the buccal mucosa. The buccal nerve innervates the buccal mucosa, but normally with the volume of anaesthetic agent that we give, we should actually block the buccal nerve. Here we have a deep dissection of towards the vertical ramus of the mandible. You can see the mandibular nerve here as it enters the mandibular foramen. You can also see that there's the branch here, which is the lingual nerve. Here's the other branch, which is the buccal nerve that supplies the buccal mucosa around the molar and premolar teeth. The lingual nerve branches here and supplies the tongue, the rostral 2/3 of the tongue, but it also supplies the floor of the mouth and also the the lingual mucosa on that side as well. You can see the close relationship to those three nerves, the mandibular, the buccal, and the lingual nerve. So if your anaesthetic agent is going into this area here, you will block the lingual nerve and you'll probably pick up the buccal nerve as well. What are the landmarks for the caudal mandibular nerve block? For firstly, the distal aspect of the third molar tooth, which is here. The angular process, which is here. We run a needle following from behind the third molar tooth in a straight line towards the angular process. This is the traditional approach. We go half to 2/3 of the way along that length, and we allow the needle to run onto the medial side of the ramus of the mandible. That is one approach. The other approach that I've developed is we measure the height of the mandible in the first molar region from the crestal bone to the ventral cortex. That's the length that the needle will go in. We bend the needle at approximately 20 degrees so that it tracks along the medial side of the ramus of the mandible. And the needle hub will sit on the main cusp tip of the molar tooth. So this is the main cusp tip, so the needle hub will sit in that direction here. The needle goes into where the height of the mandible measurement is, so we bent the needle so it's tracking along the medial side of the ramus of the mandible, and then we draw back and slowly inject in that side. So here we have a video of the caudal mandibular nerve block. We've measured the needle, the full height of the mandible. We've bent the needle at about 20 degrees. We're going behind the last molar tooth. We're walking the needle off the bone and running it along the medial side of the ramus of the mandible to where we've bent the needle. We'll draw back, make certain we're not in a blood vessel. The needle hub will be resting on the main cusp tip or at about approximately 30 degrees to the body of the mandible, and then we draw back and slowly inject into that side. There have been very few studies that have looked at local anesthetic nerve blocks in the oral cavity in dogs and cats. This is one study here that by Mullerin, and you can see the images from that study. In my opinion, this is an ipsilateral injection on the medial side, so it's pretty similar to my injection, except I think the angle of the syringe and needle's too high. It should be more down, resting on the main cusp tip of this first molar tooth. And the cat, it's probably not too bad, that angle, because it'll sit on the main cusp, which is that of the last molar tooth in the cat. There was a study that was done in back in 2016 by Goody DeAngelis. This was an interesting study. It looked at the injection of a dye, using the dye as a local anesthetic via two approaches, either the extraoral approach or the intraoral approach. Now, the degree of contact of the dye, so they used CT to see where the dye ended up. The degree of contact of the dye at the mandibular foramen was different between the two approaches. So the intraoral approach, they found that the contrast pool was present in 4 out of the 5 dogs they used it on with the intraoral approach, whereas with the extraoral approach, so the extraoral approach, I'll show you what that is shortly, the dye did not get anywhere near the mandibular foramen. In fact, this is where we use vertical from the lateral canthus of the eye and place the needle into the vascular notch. That worked, unfortunately, 0 out of 5 times, whereas the intraoral approach worked 4 out of 5 times. In humans, the success rate of the caudal mandibular nerve block is around 80%, so it does fit in with this study as well. So this is the caudal mandibular nerve block, the extraoral approach. And the idea behind this was you dropped a vertical from the lateral canthus of the eye, and that would hit the vascular notch, which is here. You run the needle half the height of the mandible in the first molar region, and you pass the needle extraorally through the skin to half the height of the mandible onto the medial side of the ramus of the mandible. So this is the medial side. There's a foramen there. Okay, so if it's going to work, it will work. The trouble is we get this needle doesn't always end up following the bone. The only time you can get this extraoral approach to work is if your finger is inside the mouth and resting on the infraorbital foramen. I'll just draw a little fingernail there, resting on the infraorbital foramen, which you can palpate in medium to larger dogs. And then you guide the needle up to where your finger is. And that's the best way of getting the needle in at the mandibular foramen site. But as you can see in the previous study, this technique works 0 out of 5 times. So I don't recommend it because it has a very low success rate. There's been a few studies done looking at the mandibular foramen, the position of it in brachycephalic dogs, and they found in brachycephalics, the mandibular foramen can be anything from 6 to 12 millimeters away from the ventral border of the mandible. So that's a fair bit of distance. So this is again why local anesthetics may not work when we're giving them for the caudal mandibular nerve block in brachycephalics. So you've got to be aware of this information. Another study in cats using a 25 gauge 1 centimeter long needle. They placed the needle 1 centimeter rostral to the angular process and advanced it 0.5 centimeters along the medial aspect of the ramus of the mandible, and that blocked the inferior alveolar nerve or the mandibular nerve. Again, quite a difficult thing. The angular process in cats, which is here, isn't that easily palpated, so I probably wouldn't recommend that approach. This is an extraoral approach. I would rather recommend the intraoral approach. So these are my landmarks for the intraoral approach for the caudal mandibular nerve block. So here we have the third molar tooth here. We have the mandibular foramen here. Okay, the mandibular nerve will run down in this area here and enter the mandibular foramen. So we have to make certain that our injection is caudal to the mandibular foramen, because if you're giving the injection in this area here, you would have missed the nerve because it's already entered the mandibular foramen. So we pass a needle the full height. So this is an exact measurement. You can see the yellow dotted line here. So that measures from the cortical crestal bone, the crestal bone to the ventral cortex. We run the needle in that full length in this area here and about 30 degrees from the body of the mandible, or we can use the main cusp tip of the first molar tooth. So you can see, even though the needle is maybe not always near the mandibular foramen, it will be near where the mandibular nerve runs, because the mandibular nerve runs in this area here. So you don't always have to be on the foramen. You can actually be just caudal to the foramen, because that's where the nerve will be running. So in the cat, the caudal mandibular nerve block, the intraoral approach, again, we go the full height of the mandible in the first molar region, mid first molar region here. That's how far we go in. We go where the demarcation of the vertical ramus meets the horizontal body of the mandible. So in this area here, so it's not just behind the last molar tooth, it's a little bit more caudal to that. This is the main cusp of the first molar tooth. If not, then you'll run it at around 30 degrees from the horizontal, and you run the needle in, tracking along the medial side of the ramus of the mandible. There's our mandibular foramen here. So just again demonstrating this approach for the cat. Here's the full height of the mandible in the first molar region in this area here. We go just behind the last molar tooth where the vertical ramus meets the body, in that area here. The needle is slightly bent inwards, so it tracks along the bone here to the full height of the mandible. So we bent the needle prior, and the needle hub would be hitting the main cusp of the distal cusp of the first molar tooth in the cat. These diagrams are just to show you that I've done some measurements on a number of skulls. So this is, if you look on the interoral approach for dogs, this is the full height of the mandible in the first molar region here. So that's the full height of the mandible here. That's how far the needle will go in. We go in between the demarcation where the vertical meets the body of the mandible. So behind the last molar tooth, we'll have the needle hub hitting the main cusp of the first molar tooth here, and we bend the needle at the height of the mandible in the first molar region, and the needle will track along the medial side of the ramus of the mandible. In the cat, it's the same thing. The full height of the mandible in the first molar region here, and the needle hub will hit the first molar cusp here, and we'll go in that full height on the medial side, and you can see that we'll be very close to the mandibular foramen. So just another demonstration of that. In the dog, we're going the full height of the mandible, the mid first molar area. I've got a little stopper here that will stop where we want to go to. So we'll go in on the medial side. The needle is bent inward slightly, and it'll go the full height of the mandible. There's our stopper. Remember, there'll be some soft tissue there, so we'll stop at the soft tissue. You can see here's our mandibular nerve running just above the condylar process and entering the mandibular canal. So you can see that we will be very close to the mandibular nerve or the mandibular foramen, and the needle hub will be setting on the main cusps of the first molar tooth. In the cat, on the right hand side, again the full height of the mandible in the first molar region. Again, the needle will track in on the medial side of the ramus of the mandible, and the needle hub will hit the main cusp of the first molar tooth there, the distal cusp, and that gives you the angulation that you need to go in at. You can see the needle will be sometimes not always at the foramen, but a little bit caudal to the foramen, but you'll still get the nerve as it enters the foramen. This is a deep dissection showing you where the relationship between the mandibular nerve or the inferior alveolar nerve and the lingual nerve. So here we have the mandibular nerve. You can see it running in this direction here, entering the mandibular foramen. There is a large muscle. You can see that muscle dissected away there. That's the pterygoid muscle. So you can see that if you are not following along the bone here and you inject into this muscle here, number one, your anesthetic will not work because the muscle will hold the injection, and number two, you may also cause a hematoma in that muscle. And hematomas, we can see that occurs in people, and that can cause something called trismus. So the hematoma causes muscle pain, and so the patient has some muscle pain on opening and closing, which limits their amount of opening and closing. So that can last for a couple of weeks post caudal mandibular nerve block in humans. If you look at the other nerve, the lingual nerve, you can see it here, running here. You can see that the branch is just a little bit dorsal caudal in this area. That's where the branching will be. So if our injection is in this area here, we may not pick up the lingual nerve, but if we give enough volume, you'll infiltrate some of the anesthetic agent to the nerve. These are the original diagrams from Dr. Brett Beckman, a colleague of mine in the United States. This was his diagrams of the extraoral approach for the caudal mandibular nerve block. As you can see, we drop a vertical from the lateral canthus of the eye. The lateral canthus isn't here, it's actually where the hair starts in this area here, so we drop a vertical. Hopefully we're at the vascular notch of the mandible. We go half the height of the mandible in the first molar region on the medial side of the vertical ramus, and we slowly inject onto that side. As I mentioned in a few slides previously, you can still use the extraoral approach for the caudal mandibular nerve block. This is myself using that approach. What we've got is we've got a finger in the oral cavity here, and that will be resting on the mandibular nerve here. And then we place the needle extraorally onto the medial side of the ramus and the mandible, and we pretty much guide the needle up to where our finger is. And so this will work because now you actually got your finger on the foramen and you can actually guide the needle up to where the foramen is. Now that I have this other approach, this intraoral approach, I very, very rarely use this approach. The following slide has a video of the caudal mandibular nerve block in the cat, the extraoral approach. They'll show you the landmarks for that approach in the cat, and we'll go through that. So this is, we're measuring half the height of the mandible in the first molar region. We're palpating on the ventral side of the ventral cortex of the mandible, and we're going half the height of the mandible in that area there, and we're slowly injecting. The landmark that we're looking for, if you can feel the ventral cortex of the cat, you'll find that it's quite thick here, and then it moves in a little bit, so the diameter narrows in this area. Where it narrows, that above that narrowing is the mandibular foramen. So this extraoral approach has been used before to basically place the injection where the narrowing is of the ventral cortex and give the injection on the medial side of the ramus and the mandible. Again, my intraoral approach, I find that it works better, and so I tend to use the intraoral approach. So when we talk about local anesthetics, we need to talk about the complications. Now, most of these complications are what we call local complications, so they're not systemic complications. So we're not normally seeing cardiac depression, we're not seeing muscle tremors, but we certainly need to be careful that we do not inject into a blood vessel. So we'll go through some of these. Some of the things that we do see is nerve damage. So we've mentioned that with the infraorbital, so we can damage the nerve, and the problem with that is that the nerve can be damaged for a few weeks post damage. So the animal may suffer with a pins and needles sensation or a paresthesia sensation, altered response or altered sensation in that area. So that may cause problems. We certainly see hemorrhage if we hit a blood vessel. Trismus, we mentioned that can occur in people where the injection is given inadvertently into a muscle. Certainly we can see tongue biting. Tongue biting will be from the caudal mandibular nerve block, and we're blocking, as you can see in the background image, we've got a dog's tongue here with a big cut out of it here, and this dog was given pipivacaine bilaterally. When the dog started to recover, it actually started to chew its tongue because it couldn't feel the rostral 2/3 of its tongue on both sides. So we had to re-anesthetize the dog. We had to stitch up all the tongue lacerations, and then we also had to put a tape muzzle on this dog for another 4 hours because the local anesthetic agent was still working. So I prefer to use lignycanine as my main go-to anesthetic agent. I don't I very rarely use bupivacaine. Face rubbing, we can see again from the infraorbital nerve block, we see sometimes the animals recovering in the cage and they'll be rubbing the side of their face, and I think this is paresthesia or altered sensation as the anaesthetic's starting to wear off. Exophthalmos we mentioned before, where we inadvertently cause hematoma formation in pterygopalatine fossa. Deafness, I have not seen that as a problem. Infection, I have not seen that as a problem, but certainly you need to use sterile needles and so forth. Scarring inside the infraorbital canal, this is usually seen with multiple injections, so we can get fibrous tissue forming in the canal. Globe penetration, a veterinary dentist out of the UK discussed that in a study that she did in the Journal of Feline Medicine and Surgery in 2015. So penetrating the globe, we'll show you some photos of that. Cardiac depression and arrest, certainly it can happen if that's more a systemic sign, but again, I haven't seen it, and it's usually when you're giving the injection intravenously, accidentally giving it intravenously. Be careful that you don't overdose, especially small pets. So we talked about neuro and cardiotoxicity. I do avoid a bilateral caudal mandibular nerve block given at the same time. I can give it staggered, so at least one half of the tongue has sensation to it as the animal's recovering. But I tend, as I said before, not to use a long-acting anaesthetic agent such as bupivacaine. I will mention there is another anaesthetic agent, bupivacaine, and that is in between lignycanine and bupivacaine in its length of action. So it'll work around 2 to 3 hours in the dog. So we have one of the complications of local anaesthetics. We have hematoma formation. You can see from a infraorbital nerve block here, so you can get a blood vessel, pierce a blood vessel, so you can get a hematoma, and that can cause some pain. You can see the large tumor here. That's why we were nerve blocking before removal of that tumor. So the other complication we can see is globe penetration. So Dr. Perry out of the UK did write up on this in the Journal of Feline Medicine and Surgery in 2015. This is photographs from her original study. You can see that she's using the infraorbital nerve block in this cat here. The needle has been exaggerated and passed in a long way. The globe is sitting here. So you can see from that situation, especially if you angle the needle from ventral to dorsal, that you will penetrate the globe. And these are some of the images of globe penetration on the left-hand side. You can see down here we have a globe penetration. Normally you can't save the eye if the globe has been penetrated. This is another intraoral approach just behind a zygoma. I rarely would ever use that approach. It is mentioned in some of the anaesthetic textbooks, but I would not recommend it. Again, the chances of getting a globe penetration is high. There was a study done by Volk out of the New Zealand Veterinary Journal, 2019, looked at the ophthalmic complications that can occur following ocular penetration during routine dentistry in 13 cats. You can see from the images here we have quite a marked inflammation occurring in the anterior chamber here and hemorrhaging as well. You can see the globe penetration, needle point penetrations in these areas here. So again, unfortunately in these situations, enucleation of the eye is often the only option that you've got. Finally, I will mention some complications that we see in humans. I'm a human dentist as well. I worked about 12 months in children's dentistry, visiting schools. This is a common complication that we can see after the caudal mandibular nerve block, where we get lip chewing and bruising from that, and swelling of the lip due to having a numb lip. So there was some studies done in that in children, and showed that the unilateral or bilateral mandibular nerve block can cause soft tissue trauma. So we always in human dentistry, whether it's an adult or a child, we warn the patient not to eat post nerve blocking. They have to wait for the nerve block to wear off. There was a case report a few years ago in children in the Pediatric Dentistry Journal that a young child had a caudal mandibular nerve block, and within half an hour went out and ate a sandwich, and she bit through half her lip. So she actually detached part of her lip due to eating that sandwich. So we definitely warn adults, and we definitely warn children or their carers that the child can't eat. The other thing that children do is they play with their lip if it feels tingly or numb, and again that can cause ulceration as well. So we definitely advise that there's no playing with the lip and so forth. That's the end of this webinar. Thank you for watching. My name again is Dr. Anthony Caiafa. If you have any queries or questions about this webinar, you can email me on toothdoctor@optusnet.com.au. I hope you enjoyed the webinar, and please feel free to email if you have any concerns or questions. Thank you. I will leave you with a final image of Iguazu Falls on the border between Brazil and Argentina. For those of you who can travel at the moment, that's not happening at the moment because of coronavirus, but please feel free to enjoy the next image.